Anu, welcome to the forum. We're
Thank you.
absolutely delighted that you're speaking with us today virtually. Virtual is good because it's very green. It's very green for radiology. We like that. So we're sorry we're not meeting you in person. We were a number of people in Cambridge were very much hoping to see you, but
Sorry.
oh no, please don't worry. Please don't worry. Another time, we'll look forward to having you up in Cambridge with us. It's not too far from London, so that's the very that's the very good news. So Anu, thank you so much. There'll be people joining the call, and again, the good thing from for not being in person is you don't get disturbed the whole time with people coming in and out the meeting. But a number of people in the department very interested in listening to your talk and hearing what you've got to say. So I know a little bit about you. Well, all I know that, and congratulations on passing your PhD.
Thank you.
So that's just mega fantastic. So that was Tristan Barrett,
Yes.
right? Was involved.
One of my examiners, yeah.
And he said you were just terrific. So well done you. That's a fantastic achievement. And he said it was excellent, and he enjoyed the examination. So really well done. It's great to get a PhD in radiology, and we're looking forward to seeing you flourish as an academic.
Thank you.
But Anna, you're a consultant already, and you're based in London at St Mark's, and you're a GI specialist.
Yeah.
Which is fantastic, so important. But in addition to that, you've really led the way in terms of equity and that's what we're really interested in hearing about today.
Okay.
Cambridge has been traditionally a kind of white male dominated university, and the hospital are less so. I think the hospital is more diverse in the workforce that's being employed, which is great. The university is changing, and one of the things that really helped was Athena Swan and Dame Sally Davis, when she was heading up as chief medical officer and had the control of the biomedical research centre budgets of the NIHR, was able to say there's not enough females. And she was focusing on females because of the number of white males, I think, that were standing in the room. But I think, in fact, NIHR is also beginning to recognise that diversity is so important, and that we need to really embrace, encourage, and support our workforce going forward from all backgrounds and all genders. So Anu, I'm hugely interested in the work that you've been involved in. You've been involved in RadReach, and I presume you're going to be talking about that today, are you?
I will mention it, yes.
Oh, fantastic. And of course our own Jade Scott Blackgrove is also involved in that, and I forgot to ask Jade today, but I'm sure she's on the line or will be joining. I can't see her name here, but she's probably sitting in with one of the groups that are currently logged in. So we're looking forward to hearing about that. But you're also on the strategy group for the Northwest London Healthcare Trust, and it would be good to hear what you're doing with them. So we're just really interested to hear how you're working at all different levels, how you're working to try and widen participation for medical students to come in from different backgrounds, and then of course how that then feeds into our own specialty in radiology, and what we can all be doing to try and help you in that endeavour. So I think, unless you'd like me to say anything else at this point,
I think perfect. Thank you.
I think that
was more than I was anticipating. Thank you.
All right. Well, we're just delighted, and we've got Ruchi's on the line. Ruchi Sinatambi, who's one of our breast radiologists. Work very closely together. But Ruchi's very senior in the medical school in terms of encouraging the undergraduates, looking at diversity and equity. And now tell me, you changed the title from equality and diversity to equity and diversity. So do you want to just start and just talk us through, because I have to confess, I was about to Google difference between equality and equity, but of course we don't quite have the AI bot, what's it called, chat GBT to say, because I wasn't able to put in that 1,000-word characters to actually ask that question specifically. So I'm going to ask an expert. Tell me what the difference is.
Well, if it's okay, I'm going to I answer that question visually.
Oh, in your lecture. Fantastic.
In the lecture specifically, because I think it's a really important distinction. But I've specifically put it at a particular point in the talk, if you like, because I think it has more impact there. So if you don't mind, can I defer? But I will definitely be
absolutely, absolutely. Anu, the floor is yours. Thank
you. Okay, so I'm just going to reshare. Is that okay?
That's great. Thank you.
Yeah. Excuse me. So thank you very much for that lovely, warm and thorough introduction. It's a pleasure to be with you this evening. I'm going to be speaking about equity and diversity in radiology. And I guess the disclaimer that I have to give before we start is that I'm very much speaking from my lived experience and interest in this topic as a Black female radiologist. So I'm specifically going to be speaking about inequity as it relates to race and ethnicity. And I will explain a little bit later on why ethnicity and race are particularly important protected characteristics for us to acknowledge. There are many scholars in the wider landscape of EDI and ethnicity and race, and I've referenced everything that I have used in the talk if you would like to look at anything for further reading, and there's also a reference list at the end if you are interested. So it's also very timely that I am speaking to you today about this topic because it is actually Race Equality Week this week. So there are lots of, if you go to this website, there are lots of different webinars and talks and things that you can engage in if you're interested in learning about race equality in general. So I have to acknowledge that part of the reason that I've been given this platform to speak to you is because of a talk I gave back in 2020. Following the murder of George Floyd, like many people, I was very personally affected by that tragedy. And that was, kind of in the midst / off the back of COVID-19 and the kind of ravaging of ethnic communities that we saw during the first wave in particular. And, my family and wider family, personally lost friends and family members during the pandemic. And so at that point, I think I really reached a tipping point and wanted to speak very frankly about my thoughts on racism and how it had impacted my profession and life. And so I gave this talk. It's a 1-hour presentation, but I encourage you, if you're interested to learn kind of a little bit more about how I got to be in this position with you tonight, then please go ahead and watch it. It's been watched all over the world, I think more than 10,000 times at this point. I think it's just an authentic sharing of what I was feeling and what a lot of people in my community were feeling at that time. And I'm really grateful for Professor Sharon Torres Gibson, who was the Dean at the time, for giving me that safe space to share with my colleagues. So that's why I'm here, and I don't take it for granted that I have the opportunity to speak about this. It's also really clear to me, and this quote really sums it up, that in as much as I'm speaking to you and I'm going to be very frank about some of the things that I'm going to share, that as a child of parents that came here from Nigeria in the 70s, that I'm in a group that's marginalized enough to to appreciate and to see and to recognize inequality, but I'm also in a privileged position because I get to talk about it. And I've, had certain people support me that have allowed me to find my voice in this area. And, speaking the truth about these experiences can be very triggering, not just for me and for people that speak about these issues, but also for the people that are hearing about them. And so sometimes the response can be defensiveness, retaliation, but really what I'm hoping is that what I share with you tonight will give us pause to reflect and to consider how we can each do better, be better, and how we can affect change in our environment. I'm grateful that I'm hopefully in a safe space with you this evening. Talking about racism and calling it out is never easy or safe, but hopefully having some self-agency and, again, taking the platform that I've been given, I can represent the voice for some of the people that, that aren't normally heard. So during this talk, I'm going to give you a little bit of historical context for race in radiology, as it were. I'm going to talk about racism and anti-Black discrimination specifically, what that looks like and how that plays out in the NHS, in radiology, and in the academic landscape. I'm going to talk about the value of diversity, which hopefully we all recognize, but just in case, I will give you some pointers, and also touch on and define equity and inclusion, as we mentioned initially. I'm going to talk about what it means to be anti-racist and also how we can move forward from where we are. So the historical context. Although diagnostic radiology may not often be patient-facing, depending on what specialty you're in, it's a key part of our patient's healthcare journey. I think we will all recognize that. Identifying and addressing race-based healthcare disparities has impacts beyond just imaging. It ultimately affects our patient outcomes. And so understanding the history of radiology and some of the resultant structural racism that we see within the landscape is really important for us to move to a position of health equity for our patients and also for our colleagues. Unfortunately, a lot of the work that I'm going to talk about initially has been done in the States, and there is a real lack of data, at least that I've been able to easily find, on what's happened in the UK historically within our profession. So that is definitely an area for further exploration. So we know that Dr. Röntgen first published on X-rays in 1895. In 1898, Marie and Pierre Curie discovered radium, and that led to a public fascination with the benefits or the effects of radiation. Unfortunately, radiation was also used to help further racist and eugenic activities. And you can see from the headline of this newspaper article that radium was studied in an attempt to lighten Black people's skin color. And radiologists also back then published on potential sterilization techniques of the so-called degenerates and women with mental illnesses. Now, when we consider radiological societies, you will all be familiar with RSNA, which is the Radiological Society of North America. It was established in 1915. And back then, you were required to have 2 current members of the society to co-sign your new or sponsor your new application. And for over 20 years, all of the RSNA's members were white. The first Black applicant for RSNA membership was Dr. William Edward Allen, Jr., and his application was rejected. The first accepted Black applicant was a Dr. Lawrence D. Scott, who was accepted in 1939. And once he was accepted, he then sponsored Dr. Allen's application. So in this photo, you can see a doctor just here, who was Dr. Charles Humbert. He wasn't actually an RSNA member, but he was allowed to fit in the picture, I guess. And it's really just to show you how homogenous the membership of the RSNA was back then. Now, I mentioned Dr. William Edward Allen, Jr. He was apparently the first Black certified X-ray technician, and he has been credited with considerable contributions to medicine, especially nuclear medicine and radiation therapy for cancer patients. He was the first Black member to be certified by the American Board of Radiology in 1935, which is an amazing achievement, but he was immediately cut down to size by being forced to take the freight elevator to sit for the actual exam because he wasn't allowed to use the same elevator as the white hotel guests at the venue where the exam was being held. Nevertheless, in 1940, he was the first Black member of the American College of Radiology, and he's widely published in Radiology, AJR, and he was actually the first Black gold medalist at ACR. He's created training programs, mentorship programs, and scholarships. Now, when you try and look at who the kind of notable Black female radiologists were, it's a lot harder to find. I did come across Dr. Ivy Roach Brooks, and she's recognized as the first female leader, first Black female leader in radiology. And she was the chief of radiology at Tuskegee Veterans Administration Hospital for 20 years. Now, both of these individuals are pioneers, but it's really important to recognize that they have been pioneers in my lifetime. Like, this was not a long time ago. And somebody who is definitely a pioneer in my lifetime is my dad. And he, as far as we've been able to determine, again, because there's general lack of data, he is the first Black fellowship trained interventional radiologist in the country. And he did his interventional fellowship in Toronto in Canada. And I still remember when he went to do that. And as far as we've been able to determine, he's the first radiologist to do an EVAR in a DGHI outside the teaching hospital network. So it's notable to be the first in any sphere, regardless of your background, but being the first can often, you kind of overshadows the struggle that you had to go through to be the first. So let's take a step back and consider the origins of racism and anti-Black discrimination. And generally, as human beings, we have a preoccupation with categorizing people based on how they look. And this dates back to the 18th century when anthropologists and philosophers categorized people according to geography, so the land mass, and also their visual characteristics. Now, Carl Linnaeus was a professor, scientist, and doctor, and he's considered one of the fathers of taxonomy. He divided man into 4 varieties corresponding to the 4 continents that were known at that time. And then he subsequently ascribed temperaments and moral attributes to those groups. Now, although there's been various revisions and edits over the years, there's one variety that has never moved from its hierarchy, and that is the so-called Africanus. We've consistently remained at the bottom of this list with the longest and most detailed and most negative description. His hierarchy had Black people at the bottom and associated negative moral and physical attributes, and that has stuck throughout time. Of course, now we recognize that human beings are actually more genetically similar than genetically different. So, beliefs about bodily difference have long shaped medical research, diagnosis, therapeutics, and these beliefs have permeated all aspects of medicine, and radiology has not been immune to this. Ideals about racial differences in bone and skin thickness appeared in the 19th century and remained widespread throughout the 20th century. And it wasn't until the late 60s that the US Public Health Service's National Center for Radiological Health reviewed this stance and raised doubts about unsubstantiated, doubtful validity claims that meant that there was a belief that Black people had denser bones, thicker skin, and more muscle, and therefore required radiologists and technicians to use much higher radiation doses during procedures. There was this thought that Black skin was perfectly opaque and therefore would resist X-rays. So these racist theories really have motivated, in the wider healthcare landscape, have motivated unethical experimentation on Black communities. And one of the ways that we've seen that play out in recent memory is the complete damage to trust between the physician and the patient, especially with response to COVID vaccine uptake and what we've seen with COVID vaccine hesitancy within really specific communities. So I'd like to now discuss the different levels on which this racism can exist. First is internal. This is usually unvoiced racism. It's opinions about people from other races For example, the presumption that a Black person, when presented as a victim, for example, of police brutality, or a Black child that's been attacked or been abused, you automatically think that they must have done something to justify that treatment. Your baseline is that, well, they must be wrong. It's never a presumption of innocence. And when you have beliefs like that, it forms part of a much wider context. Your internal beliefs about race affect the interpersonal relationships that you have. They affect the way you interact with your colleagues and the way that you interact with your patients. Do you have to challenge yourself? What are your ideologies about race? Do you believe that everybody can succeed if they try hard enough? And if you're not successful, it's because you're not doing enough, and completely ignoring the impact and the power that institutional and systemic factors might have in people's progression. You have to remember that institutions are governed by people and individuals. And when you have a single race that is predominantly represented in leadership of these organizations, you inadvertently and sometimes intentionally perpetuate discrimination. And that in turn will contribute to systemic racial issues. So we don't want to look at racism as just an individual's problem. We recognize that individual beliefs contribute to racism, but we have to appreciate the institutional and systemic nature of the problem. And that will force us to look at the root cause of these issues, rather than saying, if we can isolate this one racist person over here, that it will make everything better over there. Okay, so then let's think about the NHS and our profession. How does racism play out within our jobs? So we know that there is an attainment gap, or an award gap, formerly known as the differential attainment between ethnic minorities, that don't do as well as white doctors in academic tests and getting top jobs. In London Trust, this was a nice piece of work based on a Freedom of Information request, which looked at the success of applicants. And just in I think there were 12 out of the 18 London trusts responded to the information request. Out of those 12 trusts, white doctors that were applying for jobs were 6 times more likely to be appointed than Black doctors, or 4 times more likely to be appointed than Asian doctors. And the disparity wasn't due to the shortage of applicants. There was a particular trust that had over 400 applications between 2020 and 2021. And despite shortlisting 65 of those applicants, not a single Black doctor out of the 418 that applied for a job were given a position or offered a position at that place. So, okay, let's say that you got a job, you know, working in the NHS. We also see from NHS National Staff Survey data that of staff that report being discriminated against, 48% of them say that they were discriminated against because of their ethnic background. And ethnicity continues to be the most common reason for discrimination. And this is what I alluded to at the beginning when I was talking about my focus being on ethnicity and race, because out of all of the protected characteristics, what our staff and our colleagues report is that when they have experienced discrimination, it has been on the basis of their ethnic background. We know that internationally recruited staff have been central to the NHS. We know our international medical graduates are core to the running of the NHS, and despite relying on them, there is substantial evidence that they experience more racism, have poorer experience and access to opportunities throughout their careers. Now, just to consider that objectively, we're going to look at the pay gap. So this is data looking at medical staff, so doctors working in hospitals and community health services. And you can see that for every pound my white male colleague earns, someone like me will only earn 71p. Black men do a bit better than Black women, and white men do better than Black men and women, at 88p to every pound for the white male colleagues. And when you look at average monthly pay for full-time staff, and you look at that trend over time, you can see that although there are differences between ethnic groups, everybody's pay seems to be increasing since 2016 to 2020, except that for the Black ethnic group. And when you compare the Black ethnic group to the white ethnic group, you can actually see that the pay gap has been widening. And that has massive implications for lifetime earnings, pension, accumulated wealth etc. So if we look at data from the Medical Workforce Race Equality Standard, we can see that the number of doctors from Black and ethnic minority groups are increasing year on year, but the number of those doctors that are seen in consultant, clinical director, or medical director roles are underrepresented. So the more senior we become, the less likely we are to hold those jobs. And that's not because there isn't a lot of Black and ethnic minority doctors in the NHS. You can see from the first bar that we make up 42% of the medical workforce, but yet are only 20% of medical directors or 26% of clinical directors. So again, let's bring it back to radiology. I think we can reasonably expect there to be a mirror of the patterns that we see within the wider NHS. This was a study that looked at the proportion of staff that were considered appointable by specialty. And you can see that radiology, we're not doing so great. The proportion of white staff that were considered appointable was 73% compared to only 48% of staff or applicants for Black or Asian minority backgrounds. So we did a piece of work. This is a piece of work I did with Jade, who hopefully is on the call or with you today, and Dr. Hannah Tharmalingam, who was the previous Vice President for Oncology for the RCR. And what we wanted to do is compare the diversity of the Royal Colleges. And this data is not easy to find, that's the first thing. And from what we were able to find, we observed that compared to other Royal Colleges, the RCR are not doing as well as they could be doing regarding representation for members from a Black ethnic background or members that have a disability. And there is quite a large proportion that is unknown, so that is not reported, which in of itself has its challenges. Okay, as Prof mentioned, I recently passed my PhD Viva, so the landscape of academia is obviously important to me. So if we consider that now, there are over 23,000 professors in the UK alone, and out of that, only about 155 of them are from a Black ethnic background. We are, as a Black woman, I'm 3 times less likely than a white woman to become a professor. And when you look at, you do analysis by ethnicity and by gender, you find that out of those 23,000, only about 53 are Black female. And then when you look at professors within a clinical space, there's only 3 in the whole country. And I have to say thank you to Dr. Ruby, who I follow on Twitter, who manually tracks all of the new appointments of Black female academics in the country. And the fact that she does that and is able to do that highlights the issue. Of those 3, I have to give a special mention to Professor Amaka Ofia, who is a professor in pediatric MSK imaging and a consultant pediatric radiologist in Sheffield. So the fact that there's only 3 Black female professors, but one of them is a radiologist, is very dear to me, and she's been an awesome mentor and support of mine. So the fact that Professor Ofia is one of 3 is kind of expected when you consider the wider picture of clinical academics within our profession. The proportion of Black and minority ethnic clinical academics is not representative of the 42% of us that are part of the NHS workforce. And as you, again, become more senior, you're less likely to be from a Black or ethnic minority background. So I'm just going to switch gears slightly and just kind of remind us why diversity is important in radiology and in healthcare in general. Hopefully you'll be familiar with this. It's been well documented, it's well discussed. I've just put up a few things that diversity allows us to see. I think our goal as clinicians should always be to promote health equity for our patients. That means fair access to treatment. We want to see improved outcomes. We want to reduce disparities that are on the basis of someone's ethnicity or socioeconomic status. Having a diverse radiology department, having a diverse workforce leads to more innovation. It gives us better cultural sensitivity. We're able to develop better trust with our patients. And also it creates a better atmosphere. So what we want is a great experience for our trainees. We want them to stay within radiology. We want them to flourish. We want them to be retained within the profession, particularly because we don't even have enough radiologists to begin with. So to Prof's point at the beginning about changing the title of my talk from equality to equity, this is something that I think I became cognizant of a little while ago, in that there was, there's been quite a drive for equality. That was the thing that everybody wants to do, and it's EDI this and the E stands for equality. But actually, when you unpack it, you realize that equality is not sufficient. So equality, if we're looking at the graphic, there's a wall. This is a barrier to visibility. And so equality means that everybody gets the same support. Everybody gets to go stand up against the wall. And if you see over it, good for you. And if you can't, too bad. That's equality. Everybody gets the same. Equity is different in that it looks at people and it meets them at the point of their need. So it equips the person with what they need to overcome whatever the obstacle is. We equip our patients with what they need to have a better health outcome. We equip our trainees with what they need to be able to pass their exams. You can't give everybody the same thing, because then that ignores the fact that we didn't all start on the same playing field. We didn't all start at the same point. Now, if we were able to remove the barrier, so we remove the wall completely, then we have reached inclusion. So this now means you don't need to give people different support and different access, because you've removed the thing that was causing the problem in the first place. So racial and health equity isn't just about the absence of discrimination, but it's about the presence of values and systems that can ensure fairness, access, and justice. Okay, so on the assumption that we all recognize that racism still exists within our society and that we want to challenge it, I want to present to you the difference between anti-racism, non-racism, and being racist. So the green line represents racism, racist structures within our society. Okay, so that's the green road. So active racism can be described as the first runner. So he's actively perpetuating, he or she, or they, actively perpetuating discrimination against another race by deliberate acts. These are your hate crimers, your alt-right, all of those people that we would not normally be associating with generally. Now, non-racism is like the passive rejection or the opposition of racist behavior. So this person generally thinks racism is only really extreme, but in doing so, they are unintentionally granting permission for racist actions to still happen around them because they're not challenging it. Therefore, they're still going to be carried along the green road because of the racist structure that we are living in. Now, if you're an anti-racist person, you've actively turned around. This is an active process where you're fighting against racism. You're walking in the opposite direction to the green path. This person appreciates the institutional and systemic nature of racial matters and challenges those systems of racial inequality. This person recognizes that you can have racist impact without that being your intention, and then you're going to work against that. So talking about racism and holding webinars like this and creating forums where we can have discussion is really good and is really helpful, but we also need to be very proactive. We need to have demonstrable steps and proactive outreach. And RadReach is a collaboration between the Widening Participation Medics Network and the Royal College of Radiologists. And it was co-founded by Jade and Hannah, who are on screen, and myself. And really what we wanted to do is to promote equity of opportunity. So we're going to be giving opportunities to people from underrepresented groups to get into radiology and oncology and to stay and to thrive. So it's not just to get in and then we say, see you later, but we want you to have a really enriching training experience. And so we looked at not just ethnicity, but widening participation backgrounds. So if you were a carer within your family, if you're the first person from your family to go to university, if you are from an underrepresented minority ethnic group, you would be eligible to apply to RadReach to firstly have a mentor. We also recognize that mentorship, offering guidance and advice is not sufficient. We need sponsors. We need somebody that when we're not in the room, somebody is going to say, hey, I know a trainee that would be really good for that opportunity. Somebody that is advocating for you in your absence. We also wanted to develop a pool of mentors that can act as aspirational models, that can increase that representation and to really encourage people that what you want to do is possible. So if we go back to RSNA, they've come a long way from this picture. In 2018, they set up a committee on diversity, equity, and inclusion. And that committee does work on a whole range of topics. They've established grants for medical students from underrepresented groups. They've increased board diversity. And all of that is in recognition of the need for them to do more to represent the population and their membership. So issues such as healthcare disparities, gender inequality, social injustice, RSNA has committed to representing their members, especially those with an unheard voice, to be championed. And so the RCR last year published an equality, diversity, inclusion report, which is good. I think there's a lot of work, though, that we still need to do as an organization and as a college and as a profession. I think one of the really important things that I've seen over the last year or so is the importance for accountability. So there are a lot of organizations that made very bold promises and commitments in the wake of George Floyd's murder and the Black Lives Matter movement. And so it's kind of our responsibility as members to go back to those organizations and to say, well, hold on a second, you set up a fellowship for this and you said you were going to fund that. What's the outcome? Where has that gone? This isn't just, it's not sufficient to just be talking about these things. If we're going to do work in health inequality or disparities because we want to improve outcomes in specific patient populations who have been underserved, then we need to see those results. We need to see what's happened, and we need to be able to revisit and to rework and to continue to improve. So there are a few people who are absolute titans in the radiology EDI space, if you want to call it that. And I'm very, very lucky to be able to call the three ladies on screen friends. And they've been an immense support to me in helping me grow a platform and a voice in this space. And so I have to say a big thank you to Professor Geraldine McGinty, who was the first female president of the American College of Radiology, and she's awesome. Professor Judy Yee, who's also a GI radiologist. So by default, she's awesome, but she is also awesome and does a lot of EDI work and is chair of radiology at Albert Einstein College in New York. And Dr. Cindy Chu, who is a consultant radiologist, also GI in Glasgow, who's doing loads of work with the British Society of Gastrointestinal and Abdominal Radiology with a view to improving equity and diversity within that specific organisation. So lastly, I'm going to just leave you with, I guess, a kind of call to action. I mentioned before that this work is work that we have to do individually, but then we also have to make sure that we hold our organizations to account and also recognize our position within those organizations. So what we want to see is increased diversity amongst our juniors and our fellows, but also we want to see how that diversity can be translated into future leaders. How can we encourage collaboration, quality research within ethnic minority patient groups? I haven't had a chance to go into it today, but if you do any research, you'll know that trial participants are invariably from a particular demographic and background. What are we missing by not having a much more diverse pool of not only researchers, but patients? So what we want to do as radiologists, we want to make sure that diversity is part of our core business. We have a responsibility as leaders to ask difficult questions. And I think we have to, if you recognize that inclusivity and diversity is important, then you have to make sure that your approach is inclusive and diverse. And if you are all trying to do something, but there's no diversity in the group of people that are trying to affect that change, then you're going to have very limited impact. So I will leave you with this quote, which I hope you will understand why, why I put that here. And although I'm grateful for the opportunity to speak with you, the responsibility of addressing these challenges cannot just lie on the shoulders of the people that are marginalized. It's a responsibility of everybody, particularly the people who are currently in leadership, to try and affect this change and to push us forward and provide the necessary support for us to really move the needle on this issue. And lastly, if you are interested, there are some of the references and just a little bit of recommended reading. This is by no means exhaustive, but there are articles that I read that I found helpful when preparing for this talk, and also just stuff that I found interesting that if you're interested to, you can have a read of. Thank you very much.